Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. Now, if you are hearing this right now, then you are not currently a Journal Feed subscriber, and so you will not be receiving the full Journal Feed podcast, only getting a portion of the past week's articles. That's right, you're going to get 2 articles out of a total of 5. But if you would like to get full access to both the podcast and the blog, then you'll just have to become a member. All the details for that are at journalfeed.org. And remember, if you have any trouble affording a subscription, just get in touch and we will help you out. We never want money to be a barrier to better patient care. This is the audio version of the past week summaries, which this week were brought to you by our authors, Shannon Marcus, Denrick Cooper, Vivian Lay, Amanda Matthews, Catherine Berger, and of course, Clay Smith. All right, let's get straight into the first article, which was titled Pharmacologic Management of Acute Pain in Children, a Systematic Review and Network Meta-Analysis out of the JAMA Pediatrics. Now, of course, many people present to the hospital with pain. It's about 60% of all pediatric emergency department visits. And so it's no wonder that we are very interested on how best to treat pain. Every time I read about pain studies, I'm surprised by how little we actually know about treating it. For example, this was a systematic review and a network meta-analysis, and they found only 41 RCTs for a total of only 5,000 pediatric patients. That's nothing. That is barely any patients for a thing that we deal with so frequently as pain. It's actually kind of atrocious when that's what patients actually present for. I know it's not treating the problem exactly, but it's really a problem that people have. And unfortunately, this is the best that we have for pediatrics. That's really sad. But at least we should make use of what we do know and hopefully try to know more in the future. So let's get into what they found. Now, compared with placebo, only NSAIDs, opioids, and ketamine were actually better than placebo. And that had to be mid to high efficacy opioids, just like real opioids, not like tramadol and codeine, more like morphine, hydromorphone, things like that. So these were the only agents, NSAIDs, opioids, and ketamine, that were actually doing more benefit than harm. NSAIDs were the only agent that significantly reduced the need for rescue analgesia, whereas opioids and ketamine probably don't do that. Although it's really hard to assess exactly what that means. Like, I need more information. I need timelines. What does rescue analgesia even mean? Like, just a 1 dose and then you never need anything else? And that's only NSAIDs that do that, but then I would only give NSAIDs if I didn't think they had that much pain probably, then I might step up immediately to opioids. It's really hard to say, so I don't really know what to do with that information particularly. I'd have to go read each of the individual trials, which frankly, I'm not going to do right now. I do like to see though that this supports my practice that codeine and the like are largely ineffective. Also, I like seeing that NSAIDs did not significantly increase the rates of adverse events compared to placebo, which is great. Of course, this is in the sort of short-term emergency department type setting. Not all the trials were from emergency departments, but all the same. Whereas ketamine does seem to increase the rates of GI side effects. Although we kind of already knew that about ketamine, it's something that we have come to expect. Now, of course, like all network meta-analyses, there's a lot of risk of bias. It's hard to compare trials and try to integrate them this way. There's a lot of heterogeneity, and so it's hard to do these studies. It's easier to compare things that are very similar, and that's usually not what we're going to get from a network meta-analysis. But all the same, it's nice to be able to compare these things that haven't directly been compared. It's probably the cheapest way to do it. So I still like seeing these studies, even if you kind of have to take all of this information with kind of a grain of salt. Overall, though, it seems that you should probably start with NSAIDs and acetaminophen for pediatric pain. But keep in mind, this is kind of a shotgun overview, not taking into account specific pathologies causing these specific types of pain. It's also probably worth noting that there was a signal that topical NSAIDs were more effective than oral, but that only came from one trial, though this does kind of jive with the adult literature, so, it's something you can consider. In a spoonful, not that we have that many other choices, but it seems to be that in pediatric patients, NSAIDs, ketamine, and mid to high potency opioids seem to be effective compared to placebo. with NSAIDs having the least risk of adverse events, so probably where you should start. None of them were really any more effective than each other. Okay, let's skip straight to the third article. Titled Appendectomy versus Antibiotics for Acute Uncomplicated Appendicitis in Children, an open-label international multi-center randomized non-inferiority trial out of The Lancet. Of course, we've talked a whole bunch before about treating appendicitis with antibiotics. It's definitely a viable strategy, I'd say. However, you always run the risk that the patient gets appendicitis again. One of the best risk factors for pretty much anything is, have you had it in the past? However, if you had it the first time and then we got rid of the organ that caused the problem, i.e. did an appendectomy, then, well, it's just not going to reoccur. So there is no chance that antibiotic therapy was ever going to be better than getting an appendectomy. There's just no chance of superiority there, depending on what your outcomes are. However, there is a chance of non-inferiority. So it is possible that antibiotics be sufficiently not worse than appendectomy that perhaps they would be even first-line therapy. However, you're really just kicking the can down the road for a lot of patients. All the same, it is definitely worth studying. Now, like the title of the article said, this was an international multi-center randomized non-inferiority trial on pediatric patients aged 5 to 16 years old. They had 11 hospitals out of Canada, the US, Finland, Sweden, and Singapore involved in this trial. They were able to recruit 936 patients and randomize them to appendectomy or antibiotic treatment. Now, they had differing definitions of what treatment failure was. For appendectomy, it was a normal appendix on pathology or some kind of surgical complication. For the antibiotic group, it was the need for appendectomy within the next year. So with very differing definitions of what a failure is, it kind of gets hard to compare two groups. But all the same, I'd say this is pretty relevant. If you're comparing apples to oranges, then you've got to find some kind of common ground. And I'd say those are the things that I kind of care about. Well, more having a surgical complication. I guess having a normal appendix when you take it out, though, then you had a surgery that you didn't actually need. So in theory, if we had treated you with antibiotics, you would have almost definitely been just fine and not had a recurrence. So yeah, okay, I think that's a very reasonable outcome as well. However, we're not going to know how many of the antibiotic group of patients never had appendicitis in the first place because they were not taking them out, and so we can't see normal appendices. Anyways, at 1 year, treatment failure was 34% in the antibiotic group and 7% in the surgical group. They had a non-inferiority margin of 20%, and so they just didn't make it in, meaning that antibiotics were deemed inferior to surgical management. The patients in the antibiotic group also had a longer stay in hospital. However, this has a lot to do with protocols that were set up for this trial rather than that they necessarily needed to be in the hospital. Not only did they have to be responders to antibiotic, they also had to be relatively quick responders. Because if they weren't better after a day, then you were either offered one more day or surgery. If you weren't better on day 2, then you were getting surgery. However, I guess if you have to spend the whole week on antibiotics, then we might as well have just taken out your appendix, since most of the time you can go home same day or next day after an appendectomy. It's just a laparoscopic surgery, and so it's pretty minimally invasive. I think this all boils down to the right decision at the right time. Like, what if I was outside of my insurance coverage? Then give me those antibiotics. What if I had a wedding in 3 days? Again, give me those antibiotics. You seem to recover quite quickly with antibiotics, whereas recovering from a surgery takes longer, and we saw that in our trial as well. A lot of this is a little bit less important in pediatrics than it is in an adult who is going to make decisions because of their life and how things are, and that you're just going to have parents making decisions for the child, and usually pediatric patients don't have important life events to miss. But regardless, same sort of principle. It looks like antibiotics are definitely a viable option in some circumstances, even if obviously surgery is going to be more definitive. I have not seen a better example of when to actually run a non-inferiority trial. Here we have two very different treatment strategies, each with their own benefits. This is the best time to run a non-inferiority trial, not when you're just trying to get your drug on the market to show that it's not that much worse than what's already there. So I really like this trial. Even if antibiotics were never going to be superior, it still does have its own advantages. In a spoonful, this was an RCT in pediatrics, which showed that antibiotics for appendicitis was inferior to treatment with an appendectomy. However, the antibiotic group did have the advantage of a faster short-term recovery. Okay, that's all the articles from this week. Let's do a quick wrap-up of everything we talked about. From the first article, the evidence seems to say that we know very little about pediatric pain. However, NSAIDs, mid to high potency opioids, and ketamine are the only things that we have right now that outperform placebo. From the third article, there are reasons to take antibiotics over surgery for appendicitis, at least in the short term. But of course, you're more likely to get it again if you still have an appendix, which is what we saw in this trial, which showed that antibiotics in pediatric patients was not non-inferior and indeed inferior to just getting an appendectomy. Antibiotics worse than appendectomy at 1 year. Again, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What were those articles about? Well, there was a trial on thrombectomy for medium vessel occlusions, and it's something that we definitely need to know about. Then, how much glucose is the right amount of glucose for treating acute gastroenteritis? And finally, how many children could we benefit if we had more centers that were pediatric ready for trauma? Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.